Great. Good evening, everyone. Welcome to this evening's session with Health Professions Week. We are mentors with the Tour for Diversity in Medicine. We'll tell you a little bit about ourselves throughout the evening, but we are so excited for tonight's talk. We're going to be opening up and sharing a good deal of stories, not only about ourselves, but about our patients, our experiences. And we're really happy to share this with you and hopefully give you a little bit of insight on what it is to be in healthcare. All of us are health professionals of different varying sorts, and we hope you get out a lot out of tonight's talk. I'm Dr. Cameron Matthews. I'm one of the founders and co-directors of the Tour for Diversity in Medicine. We are a group of health professionals that travel the country and really try to mentor and motivate you more than anything in the healthcare, because this is a long road and you need sometimes to just see somebody that looks like yourself to really determine your own path. So we hope, again, you get a lot out of our own stories as you figure out what yours is going to look like as well. So just to allow my dear friends on screen with me to introduce themselves, I'm going to let them do that by sharing a little bit of their own bio. But I also want them to kind of dig a little bit deeper, guys. Don't get too uncomfortable with it, but please share with our audience. I'd love to hear kind of what about your identity, any part of your identity really shaped your choices in your career? What really kind of motivated you as you figured out what your path was? Because our identity is such a large part of who we are professionally. I think it's worth recognizing that. So I'm going to start on my screen. Dr. Darko, if you want to go first.
Hi, everyone. My name is Dr. Nee Darko. I'm a board certified trauma surgeon. That means basically I take care of people who get involved in car accidents, shot, stabbed. I also do regular general surgery, so people who need their appendix taken out or any of those type of surgeries, I do. What has shaped me from my identity into what I do is two things. One being first generation immigrant. Both of my parents are from Ghana, West Africa. Very blue collar background. My mother was a nursing assistant and my father worked on computers, and I could always remember them never taking a day off and always working hard, and education was the key to success. That's always guided me in terms of, going past obstacles, and kind of helped me develop, tunnel vision to get to where I really wanted to get to. And then the second thing is where I grew up. I grew up in Queens, New York, as well as Irvington, New Jersey, which is right outside of Newark, New Jersey. And oftentimes what I saw are the things that I see as a trauma surgeon. And oftentimes I feel like those patients can oftentimes be voiceless. And I feel that now that I'm a trauma surgeon and I deal with these patients on a daily basis, I feel like I have to speak up for them. So I feel a sense of responsibility, but a great sense of responsibility. I'm always happy to walk in and feel like I need to protect those who can't speak up for themselves. So I'm super excited to be here, and I'll leave it at that.
Love it. I love our stories. Dr. Sears, you want to go next?
Hi, everyone. My name is Ciera Sears. I am a geriatrician and palliative medicine doctor in New York City, which means I take care of old people and dying people. How my identity has shaped my path is that when I was in college, my grandmother actually got very sick and ended up in hospice care. And it was her hospice doctor who was really talking to me and really guiding our family through making these really serious decisions for my grandmother. And we all felt like we were well taken care of, which is not common, especially for Black people in the medical system. And throughout my training, and even now throughout my job every day, I experience people of color who experience mistrust in the medical system, especially at the end of life. And I feel like I can be an advocate for them and serve as a face that they feel like they can trust and is absolutely doing their best to care for them. So I love what I do. And like Dr. Darko said, I love being an advocate for people who can't speak up for themselves and to hopefully change the standard of care.
Beautiful, beautiful. Dr. Winters.
Hi, everybody. I'm Dr. Tyree Winters. I am a board certified pediatrician, and I am also have a focus in obesity medicine. So what does that mean is that I take care of patients that are age 0 to 21, actually even above 21, because as pediatricians, the common misconception is that we stop at 21, but we can actually go even further along, especially when there are conditions that you are born with that typically our adult counterparts may not take care of. And then with my obesity component of it, being able to take care of patients who suffer from obesity and being able to help guide them into a healthier lifestyle, which leads me to how my passion was fueled by my identity. Well, first, surprise, I'm Black. And so being someone who is, I know, right? It's surprising. Being somebody who is Black, especially growing up in Detroit, you would think that when I say those two words, that meant that I grew up poor and I was struggling to get by and I did drugs or I was around family members who did drugs, but completely opposite. I grew up in a very well-educated family. Similar to other folks on this call, I had great-grandparents who went to college. So with that being said, I was always exposed to individuals who never told me that I could not become a physician. And I had the experience of having a wonderful Black female pediatrician who was my role model, and I wanted to be just like her. And so that's what led me to go into pediatrics. The other part of my identity is I've always struggled with weight. I've always struggled with obesity throughout my entire life. And that was something that made me not want to sometimes go to the doctor, made me not want to seek out help, because I was always so disappointed, as well as felt always not necessarily threatened, but always felt accused that my weight was my issue, my problem, and I was the root cause of it, which thank God we have research out now that shows us that obesity is so much more than just your lifestyle. It has a lot of genetic components to it. And having an understanding when I went through my training, it allowed me to be able to now be a physician that can reach out to children that I identify with, that I was like when I was a child, and understanding that when we have a conversation about weight, it can be so much more than just talking about having a healthier lifestyle. It has a lot of psychological components to it. So being able to have that understanding has really helped me and fuel my passion with being able to help individuals who suffer from obesity.
I love it. This is all so, our decisions are so personal and clearly impact our experiences impacted our choices, right? So Dr. Prince, please tell us your story as well.
Hello, everyone. My name is Andrea Prince, and I am a pharmacist. I'm board certified in ambulatory care, which is like having a pharmacist in your doctor's office. And so I currently work in an oncology office. So oncologists treat patients that have cancer. So that is currently what I do. So I help patients and caregivers and family members know what to expect from their treatments, and then what side effects they might have, and when they need to like go to the doctor if they're having a side effect, or when they need to like escalate it quickly and go to the emergency room. So I help navigate that and help with the physicians with dose adjustments and monitoring. And so I'm not a pharmacist that works at a pharmacy that is like out in the community. I work in primarily a physician office. And so kind of what led to me and my identity and becoming a pharmacist is I come from a nice big Mexican family, and we were a very working class family. I was one of the first in my family to go to college. I was the first in my family to graduate from college. And so with hardworking parents and grandparents and whatnot, a lot of medical issues get brushed or swept to the side. And so specifically like my grandma, she had a lot of chronic conditions, but she was taking a lot of medications for, but it's almost to the point where it's like we could have done something to prevent that had we had that access, or had she not been working and caring for her family so often. And so really just seeing her take all her medications every morning and in the evening, I usually people throw those like leaflets away that come with the medications. I would just sit there and I'd read them so I could be somewhat well informed of what she was taking, so I could help her. She would drop pills on the floor all the time, so I'd try to figure out like where it goes or what it was, what is she missing. And so that kind of led me on the road to pharmacy. And then now much more, I realized I work in Southwest Missouri, which is a very like white community. And so, but we have a pretty diverse set of providers that are not white at the hospital I work for. And so my main shift in, you know, trying to advocate for myself, for my patients, and for you know, people that are of color in the medical field is to help ensure that we promote a workplace that is accepting and inviting and supports the underrepresented, primarily like Black and Hispanic physicians and providers for our patients. Thank you.
Great. So, you know what, tonight, guys, we decided we were going to make this conversation a little different. We weren't going to throw a bunch of statistics up. We weren't going to, like, you know, give our audience a lecture of sorts. We were going to really kind of hone in on a couple of key issues, a couple of key maybe experiences for each of you that really touches on race and or racism in healthcare. In our practices and how that really either affects us personally or honestly of what we observe, how it actually might affect their own outcomes, their own well-being, right? So I'm going to start with you, Drea. You talked about your grandma and how things were just kind of, you know, brushed to the side. I think maybe those of us in this same sort of setting where perhaps we don't feel as connected to our healthcare providers, that has been the case. I think most of us on here are kind of nodding our heads thinking about that. I'd love to hear, particularly from your point of view as a pharmacist. I think all the rest of us agree probably one of the most important roles on the healthcare team. Particularly, how does race and the concept of pain management come into play? Have you seen any real issues? I know there's definitely been some evidence where perhaps due to racism that we tend to not treat patients equally when it comes to pain management within healthcare. Can you talk about that a little bit?
Of course. So pain is very subjective, as you all will learn as you matriculate through your health professional career. And so with that, you have to really listen to your patient in a way to assess their pain. There are very many ways to assess pain, especially what I've seen is the lack of like interpreter use. So if I have a patient that doesn't speak English as their first language and we need to assess their pain, we need to be able to hear what they're saying and not just be like, on a scale of 1 to 10, rate your pain, end of story, because that's not gonna get across what the patient is actually experiencing and feeling. And so quite commonly we see not enough use of medical interpreters. Pretty much, I would generally say every hospital has to have a system in place of somewhat in order to meet requirements by a governing body to be able to communicate with patients effectively so they understand what's going on with their healthcare. And so quite honestly, I see pain being undertreated, especially in your like Black and Hispanic or Latinx patients. And largely a portion of that is due to we're not using the services that we are supposed to provide. So we can have medical interpreters, but if we're not using them for patients to adequately assess things, then we're not going to manage their pain well because we don't really know what type of pain they're experiencing, what level it's at, when it's happening, and what's working best to manage that pain. So something as simple as that, technology is great. It's also great when we use it. So if we were to use that technology, such as an interpreter service, as we're supposed to do, then we would be able to better treat pain for that. One of the common, I'll just call it an excuse because it is what it is, that I hear I'm like, oh, that patient's doesn't have English as their first language. Did you use the interpreter? I'm like, well, I use like Google Translate on my phone. And I was like, well, we have something that we pay for to use and that we're supposed to use for these patients. So that's like that's not appropriate way to assess the patient and communicate with the patient. Also, what's not appropriate is using like family members as translators or interpreters as well. That's just one very simple thing that we could do to we have a system in place to make that better. We just don't want to use it because it's an inconvenience or because we assume, well, the family member kind of speaks English, so we'll be okay. That's really just not fair to the patient.
Yeah, not appropriate at all. And Dr. Sears, I didn't even realize, I should be asking you as well too, kind of the same question from a palliative care standpoint. I'm sure you've seen discrepancies on how different patients are treated. Are you hearing what Dre said? You're seeing this as well too, maybe from a different perspective?
Yes. So on the front of using a medical interpreter to assess your patient, it's also not appropriate to use somebody who's not been trained in medical interpretation, because just because you understand the language doesn't mean you're conveying what I'm saying back accurately in medical terms. I think what I also see, so I deal a lot with people who have pain, specifically from cancer pain. And what I see is, if somebody's not crying out, yelling for pain, then they think yelling for pain meds, and they think that they're just fine. And people don't recognize nonverbal senses of pain, or the fact that a lot of times, especially in communities of color, if somebody is in pain and they're angry because of it, they just won't speak to you. And so now all of a sudden, oh, they're fine. They just don't want to talk to me. That's not true. They have real reasons for pain. And the other things that I really see are also like severe wounds, especially in patients with dementia at the end of life, and people won't assess the wounds or don't recognize skin changes and darker complexions. And it just leads to this whole cascade of ultimately the patient being undertreated and mistreated. So.
Undertreated and mistreated. I feel like it's the title of a book we could all write a chapter in. I love it.
Can I even interject on that one? Because it was quite interesting. Part of my role in my current position is I'm a program director for a residency program. And so being part of that, I just did a lecture for my residents, and part of the lecture is I used Black skin pictures. So pictures of individuals with Black skin to be able to show them different rashes. Well, it was quite interesting because, as all of us can tell you, as we're going through training, I'm sure you'll see this as well when you go through training. Unfortunately, most of the pictures, especially in dermatology atlases, contain white skin. They show white skin. They don't show skin or different variations of hues. It was an interesting topic that was brought up with one of my residents saying that there was a situation where there was a patient who was an African-American woman. There was concerns that she could have been having behavioral psych issues because she was complaining of something crawling on her back. Well, the resident assessed the patient, and interestingly enough, the resident, who was Southern Asian, who had a darker complexion skin, said, I didn't see anything when I looked on her back. Talked to the attending didn't see anything as well. So they were getting ready to say, like, maybe we need to admit this patient in. Other issues that was going on. It happens to be an internist was walking past, and the internist had said, well, if you look closely, you can see that this patient has something that we call shingles. There was a line that goes across what we call a dermatome, or an area of where the nerve give you sense of feelings on your skin, and no one recognized that the darkened, or what we call hyperpigmented area, was suggestive of shingles, and that can definitely cause for you to have a feeling of something crawling on you, and that would have caused that patient to have been admitted for psych evaluation.
Oh my gosh. So, I mean, just even the way we are trained I mean, right? Like we just are not used to seeing, or hopefully we're getting better at this in our schools, but we're not trained to actually look at even just different depictions of color of skin, and that changes the way that our patient outcomes come across. It's difficult. All right, let's trade up topics. Dr. Darko, you spoke on this a little bit, where you grew up, how it influenced you going into trauma surgery. I'd love to know kind of your experiences around how maybe the race of patients in your hospital coming in through the emergency department, just kind of, I can imagine a whole bunch of just dynamics in that sort of very scary scary for those of us who aren't used to trauma surgery, that sort of setting, and how race unfortunately might impact what's going on there.
Yeah. So one of the experiences that changed really how I look at medicine happened in my 4th year of medical school. I actually went to your backyard for a quick second, into Chicago. So I went to a hospital called Cook County Hospital. And I don't know if people are I think most of the attendings are a little too young to understand this part, the attendees, but there was this good TV show called ER that was a very popular show. It was set at Cook County Hospital. And obviously in Chicago, there was an issue with violence, particularly violence with knives, as well as violence with guns. So I wanted to go there to get a different experience. I did my medical school in Missouri, which was pretty rural. So I wanted to see, if I can really learn a lot in Chicago. So when I was there, most people, if you really look at where these large hospitals are that deal with trauma, the majority of them are in inner city areas or in older neighborhoods. And the majority of these people are either of a lower class, what we would deem to be a lower class, or socioeconomic class, Black or brown, or what have you. And what I noticed is there was a medical school that would go to Cook County to get their trauma surgery experience, which was not in the same, socioeconomic status. I'll just leave it to you like that.
Cool.
And I just remember learning a lot, but also all the time people were saying, I didn't get a chance to do a thoracotomy. I didn't get a chance to crack a chest. I didn't get a chance to crack this chest. This person came in, I didn't get, and what cracking a chest is it's almost the last resort when someone is about to die. You basically make an incision all the way down to their skin, you break open their ribs, crack it open, and you pull their heart out, and you try to put sutures in a hole in their heart, and you massage their heart and try to bring them back to life. It's basically it's almost as if the patient is about to die. And what I noticed when these residents and these doctors were talking about this procedure, it was almost like it was like an experiment, or almost like the patient was dehumanized. And like I said in the beginning, Chicago is just like where I grew up, in Newark, in Irvington, in Queens, New York. So these patients coming in look just like me. When I finished my rotation and when I finished medical school, I went back and lived with my parents in Irvington, which is just like Chicago. So I can't separate myself from that, right? So when I'm taking care of patients, I see myself, I see my brother, I see my sister, I see Dr. Tyree, I see Dr. Ciera, I see Dr. Prince, I see all of you guys there, because this is the neighborhood that I come from. And it was at that moment that I knew that I had to be more than just an excellent physician and surgeon. I really needed to be the person in there to say, whoa, 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 this is more than just an 18-year-old gangbanger who comes into the hospital, right? Because then the way how that relates to is when a patient survives and gets to the floor, they don't get the pain medications that they need. If they complain, people look at them as, well, they're just the gangbanger. Why are they complaining? They should be happy to just be alive. This stuff compounds itself. And if you're not careful, you can be a part of this system also and perpetuate the system. So when I did my training at Morehouse in Atlanta, I became really cognizant. They teach us to be very cognizant that even as minorities, as Hispanics, as African Americans, whatever background you come from, you too can also perpetuate health disparities. So that's how where I come from, and how it affects trauma surgery affects me on a daily basis.
Yeah, I didn't disclose to the audience, but I worked for a couple of years, just maybe a mile or so from county. I was at the other county, Cook County Jail. Y'all know I worked there. I'm a family physician, and my first job out of residency was at Cook County Jail, where the overwhelming 96, 97% of my patients, of course, were Black or Latino males. that were there, obviously, because they were justice involved. And it was just alarming, just the economic as well as educational situation that was going on there, that, you know, I talked to patient after patient that just couldn't bond out because they didn't have $100 on them. So literally we're stuck in this massive, disgusting facility because they didn't have mom or dad paying their way out or so. And just the reason why that hit me, Nee, is because the just dehumanization of the men and the small number of women that we had in there really hit me to the core as well too. I felt like I had to connect with my patients more and more every day, because I was a face that actually they felt that they could have some trust in. Because trust me, there were other Black and brown faces in there, unfortunately, in the form of security. But, you know, to be there as a trustful person that they could share information with, and that was there for their best interest, was something that was new to them. And I just took that role quite personally. So Nee, I thank you for that. My goodness. All right, Dr. Winters, let's switch up. You do some amazing work there. And again, to applaud you, you have a new position there. You are new in leadership, and I love it. With the young people that you treat on a regular basis, I know that you are advocating for them. Obviously, like you said, you do your obesity work, and that's such critical piece for adolescents. But I think the other kind of side of what a lot, unfortunately, of our youth are probably experiencing as well too, is the need to come in for maybe a little bit of assistance with regard to maybe some exposures they've had, maybe you know, as they're getting up in age and they're finding their significant others, whoever that might be, they might be exposing themselves a little bit. And as adolescents, that's a lot of education and unfortunately a lot of antibiotics we got to pass out sometimes, although not just adolescents. You know, Dr. Winters, I know you've had some experiences around how we actually treat adolescents who may have some sexually transmitted infections. Can you talk about that a bit?
Yeah, so interestingly enough, when we talk about sexually transmitted infections, a lot of times, especially when you are thinking about symptomatology or thinking about the way that people present with issues with having sexually transmitted infections, it can be very vague, and it's very hard to be able to pinpoint. A lot of times, not everybody is going to come in with what I call a leaky hoo-ha or a drippy pee-pee. And so I'm a pediatrician, so I use these terms. So with that being said, you
I'm so
may
glad
not,
this is like being transcribed.
so you don't realize if people come in. Well, interestingly enough, what happens is, and to Dr. Darko's point, to all of our points, right? If I take off my badge and I take away the stethoscope around my neck, I literally can sit in the waiting room and look like everybody else.
Yeah.
And don't get it twisted that our counterparts or our staff or others don't also feel and think the same way when they see us. And so when I was a resident, there was a situation that occurred where, and I trained at a large institution, it was the second largest children's hospital in the country, and we would have individuals that would come in, especially young teenage females. Now, anybody who knows, who did any work with adolescent females can tell you abdominal pain is a huge, if not the number one, is the number two complaint that everyone comes in with. And abdominal pain is so tricky because there are so many different things that can be represented with abdominal pain. You would see the dichotomy when it came into who came in with abdominal pain and what was initially perceived and thought upon. When a white or Asian female that would come in with abdominal pain, the very first thing that was thought about is, oh, this could be a ovarian torsion, this could be an appendicitis, this could be constipation. When a Black or Latina female would come in, it was, oh, this could be what we call pelvic inflammatory disease that was associated with the typical infections, sexually transmitted infections like chlamydia, gonorrhea, trichomonas. This could be pregnancy. Even though across the board, the first thing that we all know is even if you haven't had your period, any female that is of birthing age, where when I say birthing age is literally around 9 and above, because that's when you can probably get your first period, really even 8, pregnancy test is the first thing we do. Pregnancy test, and then we go on with everything else, because we always have to be cognizant that anything that we do, it can potentially affect the unborn fetus. So the concern that I had that I brought out one time is this girl came and she had significant pain that was located on the left side. So usually your appendix is on the right side. And I was really worried about an ovarian torsion for this young girl. And ovarian torsions are a medical emergency because if you don't, what happens is the ovary can twist on itself. And if you don't untwist it, you can lose that vital organ. And the first thing that one of the attendings wanted to do was, well, no, we really should just check for STI. And I'm like, no, you don't understand. We really need to assess for this. I'm really worried about it. And it's like, I really don't think so. And it led to the fact of when you look at, and not even trying to be too statistical here, but when you look at 2016, the AAMC, which is all of the medical colleges in the country, they did a survey of medical students and saw that half of medical students thought that African Americans had a higher pain tolerance and that our skin was thicker. So that's what led us to have a higher pain tolerance, half of medical students. So what do you think about the people who are teaching us? That is the things that we see perpetuated, and it leads to misdiagnoses or prolonged diagnoses. When I told you it's medical emergency, you got that much time to really untwist that ovary. And what Dr. Darko can tell you, surgery, it takes a while. I just don't say like, oh, I need a surgeon, and they can come in, Johnny on the spot, wheel you in or cut you open right there in the room. We have to prep things. It takes time. You have to have this way in advance. And that's what we're seeing a lot of times with disparities in regards to our race, in regards to our children.
Oh my goodness. It's so frustrating. And my goodness, we probably won't even get to COVID and the pandemic, but especially what we're facing right now with vaccines and the like. I am kind of very nervous about the disparities that are going to form with vaccine administration in our communities. But I don't even think we need to go there. That's a whole nother hour that we won't touch on. All right, before we jump to the next story, I do want to make sure the audience knows, please feel free to drop any questions in the chat. We would love to interact with you and answer some questions about ourselves, about our experiences, but of course about the topic of the evening. The other thing I'm going to do, I would love to raffle off a couple of books by one of our very good friends, Dr. Sunny Nakai, who is a pre-med advisor out in California. She's worked closely with the tour. We have a couple of her books that she published last year, really assisting pre-meds in their path into medical school. For the first 5 audience members that follow us on Instagram, we're at Tour for Diversity, the number 4, and you tag 3 of your friends in the comments. The first 5 people that do that, I will be sending you a book that will be, Sunny is just an unbelievable resource. We all really adore her, and so would love to send that to you. So please like us on Instagram and tag 3 of your friends. But drop some questions in here and we'll keep the party going. Ty, staying with you a little bit. We talked about, my goodness, the trauma that Nee sees on a regular basis coming in through the emergency room, stabbings, gunshots, car accidents, my goodness, but probably a fair amount of other forms of violence. This, we know for a fact, has an unbelievable impact on our youth. something called adverse childhood events. There's a significant amount of science around this, and I just find it so fascinating. Can you talk about that a bit, and honestly, how that definitely has impacts on certain communities?
Oh, for sure. So when we think about adverse childhood events, this is something where research has shown us anything that really can impact us along the lines of our childhood that goes beyond directly things that are affecting like medicine-wise or having an infection or something along those lines. But things that you think about like a divorce, having a family member who was shot, or having a family member who was laid off of work because of COVID and didn't get a chance to go back to work. Any of those type of things can have a lasting effect. The effect not only can affect the way that you will later on develop in life, meaning so you could potentially have even changes within your ability to be able to gain understanding in school, your relationships that you have in school and beyond, seeing adults, seeing how Dr. Darko said the 18-year-old that was a member of a gang that had to have a open chest, that's still technically is still a teenager, right? I just had that conversation. Pediatricians, we still see those folks. These are all things that can affect us. What really is the scary part is it can affect something that we call epigenetics. So the way that we actually express our genes. So we know that our genes will, when I talk about our genes, our DNA is what allows for us to be able to express a lot of things. So individuals, when I talk about obesity, let's use obesity for ease. Obesity can lead to things such as comorbidities or processes like diabetes, high blood pressure, high cholesterol, things we typically would see in the 40s, 50s, we can see in children that are 10, that are 12. Well, when you add on adverse childhood events that can affect the way that we express these genes, that means that an individual that may have diabetes that developed at 10 or 12 could actually have a worse case of diabetes compared to their counterparts that may not have adverse childhood events. So they may not respond to the medicines that we typically think they should respond to. They may have an overreaction to certain things or certain events. So say, for instance, they may develop kidney issues or eye issues earlier on based off of those events.
So
How do
Ty,
we control
not
that?
just PTSD. This is the actual
This is actual physical, yes. And when we saw that and we see that there's actually data, and a lot of things about medicine is driven by data, that's the scary part. That's the part where we realize, like, yo, we really have to target this. Places like California actually instituted a healthcare professional, a pediatrician, a Black female pediatrician, to lead on adverse childhood events in that state to try to mitigate that, to be able to prevent the things that we're seeing later. Because let's face it, these individuals will later on become adults. And when we're thinking about our health system as a whole, this can affect how much resources we have to go around to really distribute to everybody.
So when we're talking certain communities maybe that are exposed to more trauma in different ways, if there's violence on the streets, if there's police brutality, if there's perhaps violence in schools, you know, they're not in that perfect private school or whatever, this could have long-reaching effects. Yeah, I mean, there's so many things you can extrapolate from there, especially when you're saying even just divorce and kind of family life, that can also have some impacts as well too. So that's so concerning for our youth. I think we have a question that we will get to in a second. Thank you guys for dropping that. I'm just going to turn right to Ciera. Dr. Sears, we have you are such an unbelievable resource. We are so happy that you, first of all, are in the type of medicine that you are. Like, I don't know, honestly, that there's many people, period, let alone people that are from our own communities working with our community members on end of life care. Like, in my mind, you are like an angel, just because like, for real, this is such a difficult space in medicine in the first place, let alone recognizing what we need to do about this in certain communities. Where do you see, I mean, you were able to talk about pain and oncology care, like Dr. Prince as well too. That's obviously, although not always, end of life care, but are you also seeing, like, particularly in the hospice space or anything where there's some disparities? What does that look like?
Okay, so yes, I am a hospice doctor as well. I do that sometimes, even though Dr. Darko thinks I don't know who George Clooney is on ER. So yes, I do see this, and I want to talk about this a lot. So one of my other interests actually is cost management in medicine, which largely drives outcomes and how we actually practice medicine. So I just completed my MBA in healthcare administration a couple of months ago, and have been using that to help our hospitals look at costs, particularly at the end of life. So it's a known fact that of the amount of money that you will spend on healthcare, you will spend 30% of that in the last year of your life.
Mm-hmm.
So you live 100 years, you're going to spend 30% of your medical dollars from year 99 to 100. We also know that Black people especially, but also people in color in general, are underutilizers of end-of-life services. And we know that people who enroll in hospice are happier at the end of life, more satisfied, their families feel less burdened, and sometimes people actually live longer. So you take this very vulnerable population of people, so people who are old, people who have a lot of the diseases that we don't find interesting and we don't want to deal with. Like, people don't want to deal with dementia and having to explain things 3 times a day. People don't want to deal with these gaping wounds that require a lot of care, and old people, like, they talk slow, it takes a long time. A lot of people don't want to do that stuff in the hospital. So you have a vulnerable population, a system that unfortunately is broken in a sense of geared towards cutting costs, and then you have these implicit biases. You put all that together and it leads to discrimination. And so what I see a lot of times is our Black patients, they feel like the hospital is not offering them a certain treatment, or saying that, you know, this is the end because they are Black, and they think that the treatment is being misheld. And, or, you know, they need somebody to explain it to them in a way that they can understand. So one of the things that I charge my residents and medical students to do is, when they speak to patients, not to use medical jargon. You know, it took you how many plus years of education to be able to understand all this medical terminology? Why would you think that somebody who comes into the hospital and is very sick can understand what it is that you're saying? And we're often having very delicate conversations. And if you loop that in with medical jargon, all they're going to take away from it is, I'm sick, I need this surgery, and you're not offering it to me, as opposed to all the other nuances of that conversation. The other part of my job that is interesting actually is that sometimes I am the one advocating for more treatment for patients. So I can tell you a case. I think, Kim, I think I talked to you about this, because I got, like, I had to go to the principal's office about this. So this was when I was still in fellowship, and I had 2 identical patients. One was a Black woman, one was a white man. They both had the same kind of dementia. I think they were 2 years apart, but they had about the same functional status, and both lived in a nursing home. One had got $1 million neurological workup to figure out why he was not communicating, why he was not eating. I'm talking total body MRIs. He had gotten like a lumbar puncture. He got all these specialists to come in and figure out what was wrong with him, just for palliative care to come in and say, he has dementia and it's the end. The patient next door to him, she got 1 CT scan of her head, and it turned out she was having seizures, and palliative care was the one who caught it. And so they they called me into the principal's office because, you know, they were like, well, why are you palliative care asking for all these studies to be done? And I was like, well, you know, this is my clinical assessment, and I can't in good faith tell the family that we're at the end of this patient's life when we don't know. And she got, you know, it turned out she was having seizures. They treated her. She woke up and she went back to her nursing home.
What?
So what are we doing? Whereas the white man went to hospice, as he should have, because we did the $1 million workup, we know. So yeah, like Ty has been saying, like Nia has been saying, like I look like these little, everybody that's running around the hospital. You know, I got my fro out, I got my tattoos out, I got my Jordans on, and I walk in the room and they're like, who's this little kid just trying to tell me what to do? And I'm like, you know, honestly, Grandpa,
Dr. Sears.
yeah, I'm the attending physician on the service, and I wouldn't lie to you. If I didn't think this was right, I wouldn't tell you that. Okay. And I'm here to go to bat for you so you don't have to do it yourself. And it's sad, it's hard. I definitely feel the burden of this because, you know, with being one of a few in a field, there is a degree of tokenism that you have to put up with just so that more can come along afterwards. And that's kind of where I am right now, you know.
Thank you, Dr. Sears. Thank you for being there. Thank you for advocating for that. She went back to the nursing home. Like, this is just.
The nursing home. She's on my list of interesting patients, actually. She's still alive. That was like a year and a half ago. So.
All righty. Beautiful. All right. I have a question from the audience that I think is a perfect one, as we're really clearly talking about how we've been advocating for our patients during medical school, pharmacy school, and in the healthcare field. How did you become an advocate and teach other people who worked in the healthcare field who are not minorities and patients as well? How did you figure this out? What did you have someone show you the way? Like, how do we take this on, right? Because we all have our own kind of almost not battles, but we have our own space where we need to figure this out for ourselves, right? How did you guys become such strong advocates?
It's
Anybody
scary. It's scary. Like, when you're young in a younger position and you see something like wrong going on and you know that somebody is being mistreated, it is scary to call it out because you're worried about what's going to happen to you. But ultimately, like, we went into this field for a reason, and the heart of that reason is patient care. So the way that it worked for me is that I would try to find somebody and that I could talk to and pull them aside and say, like, I'm not trying to step on no toes, but this is what I saw from this. And I love the phrase, for my educational purposes, what do you think about this? That way it's flipped, like, oh, I didn't even think about it that way. Fortunately, now as an attending, I just kind of say what I want. So you guys will get there one day.
Well, for me, because, you know, what I do is a lot of people, if I don't make the right decision or if my team doesn't make the right decision, somebody may die, and they may die like in the next 5 minutes or in an hour. It really goes back to what I was saying before. Like, I really connect with every patient, whether they're white, black, whatever background they come from. I don't just look at that person as a patient. I look at that person as, this person is part of a family. So if I have a 55-year-old person, or even someone with Dr. Sears, if we're sharing a patient who is very who's very elderly, and maybe the last year of their life, I'm thinking this person has a bunch of grandchildren who want to make sure this patient is doing okay. They want to make sure that, you know, mom or, you know, their nieces get a chance to see them in a very respectful way. And I think really once you're able to make that connection, you can't help but not fight for that patient, because you see them more than just a patient. You see them as someone's family member, brother, sister, or you may see yourself in them. And I think for me, once I've been able to have that connection, it's gotten me in trouble a lot. But oftentimes I look back and I'm like, yeah, I did the right thing, because that's what we're all getting into medicine for anyways, not to treat a number or to treat an 18-year-old blah, 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 is to treat, you know, you or what have you. You know, think about what it's like if you ever had the tables turned around on you. If someone was not listening to what you had to say, or someone was belittling what you had to say, or dismissing what you had to say when you were sick, when you had abdominal pain or what have you. how would you feel?
Yeah.
And if you can grab that visceral feeling and turn that around and do that to every patient that you have, I think you won the battle.
Yeah. Exactly. Yeah. Ty, go ahead.
Oh, so I'm a church boy, and all I can say is it's a scripture from Jeremiah. It was like fire shut up in my bones, and I didn't scream it out. It was gonna burn me within, and that's how I feel sometimes. Like I just have to get it go, and that's how I became an advocate. When it's like you just get so sick and tired of being sick and tired.
Tired of being sick and tired.
It just that's how my mama used to always say is when you sick and tired of being sick and tired, that's when you finally gonna do something about it. And she was so right. That's when I started to do something about it, when it was just like I just couldn't be quiet any longer. And I would look at other people, and I was just thinking about another movie, The Help, when she just looked at her and she said, "Ain't you tired, Miss Silly? Ain't you tired?" And that's what I looked at some of my colleagues and said, "Ain't you just tired? Ain't you tired of this?"
Right. Oh my goodness. Yeah, I think for me, I knew I wanted to be more than just a clinician, and y'all have heard this story, but my whole career has been advocacy, right? And I always knew that there was no way that I was going to go into exam room after exam room and after exam room doing the same thing, which is just putting a Band-Aid on something, putting a medicine on something, as opposed to how are we going to actually prevent these people from getting this high blood pressure, this hypertension? How are we going to prevent them from becoming obese, or even prevent them from having cancer in the first place? Why are we so reactive? And so for me, then recognizing and learning more about the disparities of how our communities are actually facing all of the above, there's no way that I could sit back and just treat disease. I want to help people stay well. And part of that has to be advocacy, because we won't fix our system and we won't fix these disparities if we don't advocate for larger solutions than just throw some medicine at it, right? So real quick, Drea, speaking of prevention, I think we have one more vignette that we can get to. Particularly in oncology, you obviously are doing kind of exactly what I just described, which is treating that disease, which is just so critical. And thankfully, we do have a lot of breakthrough opportunity where we can actually cure cancer, right? But again, the goal is how do we even make that impact to prevent it in the first place, right? And there's huge disparities there as well too. What do you see in this space?
Yeah, so cancer is a very broad topic, but one of the areas we do see disparities is in screening. So you can get a patient can get a screening for breast cancer, a patient can get a screening for prostate cancer. One thing, to get the screening, you have to have access to the screening. You have to know when you need the screening. And the great thing about screenings is that the idea is to catch it early, because if you catch a cancer in an earlier stage, usually we have better outcomes. If a cancer gets caught in a later stage, then that's when we have what we call poor prognosis or potentially poorer outcomes. So the likelihood that the patient has X amount of months, years to live becomes shorter. And so, like I mentioned before, prostate cancer. So specific to Black and African American men, they are twice as likely than white men to die from prostate cancer. And like I just mentioned, one of the ways we can find prostate cancer is through screening. And so ensuring that it helps to have people that look like you, that are your doctors, so that they can advocate for you, just like everyone was mentioning here. And so that you can get those screenings at an appropriate time. You have access to those screenings when you're supposed to get them. Another type of cancer where we see higher rates in Hispanic, Latina, and Black and African American women are cervical cancers. So one way someone can get cervical cancer is through HPV. And what do you know? We have a vaccine that can help prevent that. Dr. Winters can probably speak a lot to the HPV vaccine. However, usually it's in like younger men and women where they're eligible to get that vaccine. However, as I mentioned before, we have to have access to that. And patients have to know that they need to go get their pap smear so they can have screenings so that we can try to catch these cancers in an early stage and also get the vaccine to help prevent the cancer. So those are just two really easy, simple ways that we can help prevent or catch cancer at an earlier stage. But there are many other disparities among cancer that have to deal with, like race, and in the interest of time, there could be a whole like 2 hours on that topic. But in the interest of time, I'll just cut it off there. Those are two simple things that we see a large disparity in the Black and Brown community.
So important, Andrea, that you brought up the vaccine piece as well too, because again, we're not going to talk about COVID, but I mean, honestly, the fact that we're talking about access to care, we're talking about lack of insurance coverage, like Dr. Sears was talking about the finances behind it. I mean, this is so much bigger than just looking at the numbers. We have to understand the reasons behind these disparities and again, be the advocates to try to change it, right? So I have an absolutely great question, guys. I absolutely love that this student asked this. It's exactly what we want out of this conversation, so bravo. Here we go. What is something we should focus on as future healthcare providers to eliminate prejudices? I love that question. I love that question. Even before you get into healthcare, we need to be thinking about how we eliminate prejudice. How do we do that? Anybody got thoughts? I'll tell you one point blank. Dr. Winters asking his colleagues, aren't you sick and tired of being sick and tired? Having the conversations with your friends, with your colleagues, so that there's a larger understanding of what we call cultural competence of all members of the healthcare professions, understanding all their patients, valuing all their patients, treating them with a level of equity and respect that they all deserve. I think in my mind, that's how we eventually will eliminate prejudice, that we have to have these very conversations. And then we shouldn't just be preaching to the choir, but that we need to bring in those who perhaps may be a little uncomfortable when we're saying, are you sure that that isn't a seizure that we should work up like Dr. Sears did? You know, calling it out. I think that's where we have to start. So as future healthcare providers, it's about educating yourself enough so that when you can get into that space, of course, you're not going to tell your doctor right now, you're not there yet, right? But when you get into the space where you can have this conversation, or maybe just with your friends now, talking about disparities, talking about these impacts, talking about how one community looks like this, but you just change that zip code and change the income level on another community and their healthcare is completely different. That's something we have to just discuss and address.
I would also say 2 points, and I think that's an excellent question because we get that question quite a bit. The first thing that I would definitely say is that voting is key. Making sure that you utilize your enfranchisement and you use your civic right to be able to speak your voice is huge and is important. We're seeing that even now more so. It's a reason why we're seeing so many different targeted places for us to be able to silence our voice. And I'm not just talking about the Black and Brown voice. I'm talking about the woman's voice. I'm talking about the LGBTQIA voice. I'm talking about anybody's voice who is not in step with being a homogenous society. That's the first thing. The second thing that I would definitely say is that you have to understand that you can burn yourself out if you try to take on too much. None of us can change the whole system by ourselves. We need each other. So you need, the same way as you're having those conversations with other people, you need to have somebody who you can definitely share that load and that burden with. Meaning that you'll be surprised. Every little small step, every little small inch makes a huge difference. That little drop of on against that rock is going to wear that rock down eventually, and we're facing a big boulder here. So make sure you don't burn yourself out, and you make sure you have resources available to keep yourself from burning out, because you do get tired. We all get tired dealing with this. So don't forget to vote, and don't forget to make sure you don't burn yourself out. Every little small step, you are making a change, regardless if it's just for one person.
Oh my gosh. Oh my gosh. This you guys see, these are the reason why I consider these 4 people on here and our whole tour family, just my family, my heart. And I absolutely appreciate that message. What I think we need to point out more than anything is that as much as we're highlighting, I think we've highlighted some real negativity, right, in healthcare and our healthcare system with some colleagues that we've worked with. I think we have to recognize that we consider ourselves part of the solution, right, and that we need other future healthcare professionals to come into the workforce to help us continue to find solutions. So, you know, I hopefully you guys aren't taking away too much of a negative message, but that you have those of us on the screen here ready and willing with open arms to accept you into healthcare. And we are so eager for you to join us and continue to diversify with your thought, with your skin, with your body, everything. Diversify the workforce so that we can help the patients that we serve. So we thank you guys. Thanks for spending the hour with us. Again, we are the Tour for Diversity in Medicine. Please follow us on Instagram, Facebook, Twitter, Tour for Diversity, the number 4. And check us out. We've got more programming even at the Health Professions Week. We thank you guys so much for joining, and we are out for the evening. Bye-bye, guys.